I think, like a lot of people that are in palliative medicine, generally, especially after a long career practicing, seeing some of the ways that we approach diseases and chronic illnesses in this country, I think a lot of times we've lost sight of the fact that patients and families have preferences as far as what they want. And by virtue of the way our system is developed, a lot of times we lose track of that. And we have a very much a kind of an algorithm-driven system where people don't really get the opportunity to have a voice in what they want. And it's a very common occurrence that we end up having patients that are in the hospital where either the patient verbalizes or the family verbalizes, these things that you're doing to me, I never wanted, and I would have never agreed to. And so I think that's part of it, just seeing that a lot of times we rob patients, especially in their last days of life, of the opportunity to do the things that they want to do. If you survey citizens in the United States, 80% of people verbalize the fact that when they get to the end of their life, they want to be at home with their family, their loved ones. But by virtue of the way that our healthcare system is devised, only about 20% of people actually get the opportunity to do that. And I think that's really sad for those families that they're not getting their own desires heard, and we're not honoring our patients and our family members in the way that we should and that we could. So that's part of my reason for my enthusiasm about taking care of people with a more of a palliative approach. I think as a speech pathologist, and as it impacts with the ideas surrounding feeding and eating and nutrition, I think those are all highly interrelated and something that we deal with on a daily basis. I think one of the things that is humanizing to us is the opportunity to eat and to share meals. It's not just a caloric sort of event. It's not just about taking in nutrition and calories, but it's one of the things that allows us as human beings to interact. And in fact, as a human being, it's one of the first interactions we have with any other human being, right, from the time we're born. And it's an instinct that we have throughout our life, and it's an instinct that dissipates as we get to the end of life. And a lot of times I think family members don't understand that. They see an elderly or an infirm or very ill person who has developed an anorexia as a result of their disease and as a result of various hormonal influences, and the family thinks, often wrongly, and physicians too, that, well, if we could just reverse this aspect of the patient's anorexia or aversion to food, then we can improve them. And that's usually not the case. It's so often we see patients who are not dying because they're not eating. They're not eating because they're dying. Like any other thing that we do in medicine, there are indications for tube feeding. And so, but there's quite a leap from saying there are specific indications in which this will benefit a patient to saying, therefore, it should be offered to anybody, or worse yet, it should be presented to a patient as though this is something you must do. And that's what so often happens. We tend to have this notion that if a patient for some reason fails a swallow valve, that automatically equates to you must have tube feedings. Now, there's certainly times where enteral tube feeding is of benefit, and such as certain head and neck cancers, patients with ALS. In those sorts of situations, there may be some benefit to it, where there's a mechanical obstruction or barrier that's preventing the patient from obtaining nutrition. If you're looking at it with regard to patients who are, say, elderly and specifically in dementia patients, there's a fair amount of good data to tell us that it doesn't benefit the patient in terms of the things that we think it's benefiting them. Specifically, that people get, the thing that seems to always drive the tube feeding discussion is the quote risk of aspiration, in that, well, if they fail their swallow valve, then they're going to be at risk for aspiration, and somehow if we go to an integral approach for feeding, we're gonna obviate that risk, and it's not true. As you know, it does not reduce the incidence of decubiti, and in fact it may worsen them slightly, because patients who are receiving integral feedings tend to develop diarrhea, which tends to develop, promotes a sort of a milieu where decubiti can develop. And it's also unnecessarily burdensome to patients and to families, because the one thing that is certainly increased by placing integral a feeding tube in an elderly patient is the incidence of restraints, which again is a dehumanizing sort of process. And I was recently read an editorial in the New York Times by a cardiologist who was making the point that human rights advocates have objected to the fact that we were force feeding prisoners at Guantanamo Bay as though it were inhumane, and at the same time we do that daily to elderly patients in hospitals and nursing homes throughout the country, patients who are clearly telling us we don't want integral feeding, and our healthcare providers are frequently resorting to restraints to keep a PEG tube or a Dobhoff tube or a nasogastric tube in that patient in order for us to do what we think is good to the patient, i.e. pumping calories in them, and they're sort of missing a lot of the key points in that this is not what the patient wants, and we're not maintaining that person's dignity when they're in their last days of life.